Good evening, everybody. We welcome you all to this session of Smart Resident Teaching Program. And today we have a very important topic to discuss, that is management of localized CA prostate by radical prostatectomy and the anatomy associated with that particular thing. And for this particular talk, we have none other than Dr. C. Mallikarjuna with us. His achievements are such that he needs no introduction. I can introduce him in a single line saying that as far as robotic and laparoscopic surgery is concerned, his energy is equivalent to, which makes him, I feel, to be called as and labeled as the Virat Kohli of laparoscopic urology and robotic urology in India. I would now request our President, Dr. Sanjay Kulkarni sir, to give his opening remarks.
Thank you, Dr. Gyanendra. So for Urology Society of India, we are proud to have a star attraction like Mallikarjuna, who is our past president. And I know him for many years, and we have done workshops together, starting with Yashoda Hospital. And recently we were in Hyderabad on 1st and 2nd of April, where he showed fantastic laparoscopic surgeries, and he really mesmerized everyone by his skills and anatomy demonstration. He was in Pune a few years ago at D.Y. Patil Hospital, and he could demonstrate all the layers of the fascia surrounding the prostate. And by just reading the books, we don't understand them, but his dissection and showing the different layers of the anatomy was fabulous. So we are lucky to have a strong attraction, Professor Dr. Mallikarjuna, a very close friend of mine, and I'm happy to have him as the speaker today. Thank you very much.
Thank you so much, sir. You are perfectly right. It's very rare to have a combination where there is clarity of thought, which is as clear as the clarity of dissection. And you can definitely appreciate that in the surgical skills of Dr. Mallikarjuna. May I now request Dr. Lakshman Prabhu, our secretary, to say a few words before we can hand over the session to Dr. Mallikarjuna.
Good evening, everybody. Sanjay sir, Malik sir, G.R. Sharma ji, Professor Chalwa, Madam Sujata. I would like to quote a very old surgeon by name Ian Aird, who had created a single author book called Companion to Surgical Studies. Sanjay sir might know it. In that, there is a statement that a surgeon should know his way through the human body like a cabbie does through the streets of London. London cabbies are supposed to be professionals, and they are known to take you through the traffic to your destination by the shortest possible route, and without wasting time, they will pull exactly in front of your destination. So therefore, the importance of surgical anatomy, by laparoscopic and by robotic routes cannot be therefore overemphasized. Who other than Dr. Mallikarjuna to demonstrate the surgical anatomy, as it is seen through the robo when it comes to radical prostatectomy. So I would say that we are lucky today to have him as a faculty. And I have an old grouse which I would like to document here, that I could never extract a write-up from Dr. Mallikarjuna et al. From ISU group on this very topic. I had made several appeals and written, but they had not obliged. So I am looking forward to very grudgingly that, today we will have something from him. Sir, I would also want you that long ago, I think, almost a couple of years ago, you're talking about the sphincter upon sphincter within sphincter. At some stage, you should explain it, through your robotic video, and also probably make use of your hand. So we were all under the impression that the sphincter is one upon the other, but you are trying to give us a different take on that, which you have realized. So this is what I am looking forward to. Sorry, I took a little more than that, but we are all very, very eager, all ears and all eyes for this. Is going to be a fantastic webinar, in my opinion. Thank you very much, Indian School, and then thank you very much, host Dr. Shah, to you.
Very true, sir. This is the mesmerizing personality of our speaker is exemplified by the fact that when it was 7 o'clock and 2 minutes, we've had 20 participants and now it has gone to 64. And I'm sure the number of viewers who would be benefited by his talk would be in hundreds, not in double digits. I think we can spend a lot of time describing the personality, skills, and knowledge of Dr. Mallikarjuna, but that would be biting into his time. And I think I should hand over the stage to Dr. Mallikarjuna. Please, sir, we are all here and all ears for your talk.
Thank you, Sharma. President Sanjay, Secretary Lakshman, ISU Dr. Chawla and Dr. Sujata and Dr. Sharma. Thank you very much for giving this opportunity to share this knowledge, what I acquired, probably minimal knowledge, what I acquired in the recent past to you in explaining about. Okay, are you able to get it? Hope.
Yes, sir.
Okay. Because we are talking about, let me close this, okay. Surgical anatomy of prostate and application of that surgical anatomy in radical prostatectomy. I'll take around 15 to 20 minutes to explain it in figures. I don't have any text in it. And rest of the 35 minutes I'll take for showing the same thing in a radical prostatectomy done by a robot procedure. And then you can watch that at that point of time. Let us look into what is the learning objectives today. We should understand about the facial planes around the prostate, which we talk too many times, somebody calling about intrafacial, interfacial, extrafacial, what that facial planes around the prostate really mean to us. The second point is going to be the neurovascular anatomy. We talk about neurovascular bundles and we see two lines of fat there and we realize we have preserved the neurovascular bundle, but in otherwise it should have not happened or it would have not happened. What does that neurovascular anatomy means? Third point which we need to understand is what is this continence mechanism? How does the continence exist and how does the patient be continent after a successful robotic radical prostatectomy or any radical prostatectomy in fact? So understanding this anatomy and how to exploit this anatomy to improve the outcomes. That means saving the sphincter, saving the bundle, understanding the facial planes and having a clear dissection during the procedure. So this is what we are going to learn today. So what are the prerequisites before we exploit this anatomy business? What are the prerequisites? First of all, you should know the anatomy. You see, there is no way to learn the anatomy. I understand you should have a basic understanding of the anatomy beyond which we can learn on a robotic way because the magnification is better. What we saw with the naked eye during our anatomy dissections is nothing when compared to what we see in a robotic or a laparoscopic way with a big magnification. So baseline anatomy should be known. Second thing is, it has become a norm of late to do an MRI or a regular MRI to understand the architecture of the prostate and the location of the tumor, etc. So read the MRI carefully because location of the tumor, periprostatic planes, etc. are essentially to be seen well before we attempt to understand the anatomy better. And the third thing, this is essentially needed for pre-op planning. So you can think about which case you have to do an interfacial, which case you have to do intrafacial, which case you have to do extrafacial has to be learned much before. You go with a plan inside. And one side you may do intrafacial, other side you may do interfacial, one side you may do extrafacial, other side you may do interfacial. So this planning has to be done much ahead in advance by reading MRI, understanding the location of the tumor, and then planning it preoperatively. And the last one, but not the least, send the specimen together and retrospect with the histopathological examination, report what has come after some time, whether what you thought as a tumor and what you thought is a margin, what you are given, is it correlating with the MRI findings and your clinical evaluation and pre-op planning or not? If you don't have this introspection of yourself, what has happened, and or a retrospection or whatever you say, you'll not be able to perform better. So the reasons why you should start when you should start exploiting this anatomy is when you can satisfy all these objectives what are supposed to be done. Let us come to embryology. I'm not going to go into the details of embryology. Let me be very sure. I'm not going into the details of embryology. I took this subject only for some small description what is necessary for. Number one. What is this embryology of prostate for? When you look at embryology, it was a urogenital sinus, and there is a prostate, it's all bladder, and there is a urethra which is developing, and the prostatic, there is a small gland things on both sides which develop and form a surrounding mesenchyme will form a prostate over a period of time. That means what? At one point of time, there was a bladder muscle or probably urogenital sinus muscle, which is metamorphosing into the bladder and the urethra already, and the prostate is a later development which happens over a period of time. That is the thing what you need to see. And this is the prostate, and this is the muscle of the bladder which was going and attaching onto the pubic bone, and this is a urethral muscle which was developing. So you understood this point. Let us come to the later points. Over a period of time, the prostate develops and develops and develops, and there is anteriorly it is restricted with the attachment onto the pubis because of the puboprostatic ligaments, etc. And the detrusor will come up to this point, and the urethral muscle come up to that point, whereas posteriorly it grows significantly, and then there is a recession of the detrusor muscle and the urethral muscle there. So ultimately what you look at is anteriorly you have a detrusor muscle and a sphincter muscle here, and the detrusor muscle growing up onto the prostate, that's called detrusor apron, and the urethral sphincter muscle which was existing already and growing up onto the prostate, that is the apron of external urethral sphincter. So because these yellow things which have developed later, they never existed. They are all things were continuous. There's an internal sphincter which is continuously there. There's an internal sphincter muscle which is there, lysosphincter that's called. It is continuous. But this prostate has developed later. So these aprons on the anteriorly exist and posteriorly don't exist. So you see that there is an external sphincter apron which are on the prostate, and there is a detrusor apron anterior to the prostate. This is what we should notice. So these are the point of learning at this point of time. Coming to the next point is facial coverings of the prostate. Let us look at the facial coverings of the prostate. Let us look into the embryology again. This is a outside paratus, and this is a viscera. This is a urogenital sinus or a cloaca, whatever you call it. It is existing there. And there is an endopelvic fascia which covers over a period of time. There was nothing but a thin membrane of mesenchyme which was there, and the same thing is an endopelvic fascia which is covering. So it is a visceral layer and the parietal layer of endopelvic fascia. As it grows over a period of time, the prostate engulfs into that area, and the two layers become fused to one. So there are two layers of the endopelvic fascia coming fused to one, and that is a compartment which is there. So under which the prostate is lying. Fine. When it lying in the anteriorly, posteriorly the denonular fascia will develop, which is nothing but invagination, again urogenital cloaca being divided into two with a urogenital septum, urogenital sinus anteriorly, and that denonular fascia will make it into a single compartment. This is a single compartment lined by endopelvic fascia, denonular fascia, and into which the urethra exists and the prostate starts developing. As the prostate grows, as you all know, it's just glandular into the thing. It doesn't have a capsule per se. So as the prostate grows, there is the tissue in the mesenchyme here will continuously to get compressed, and multiple layers of fascia will form. So what is existing? There is a prostate gland without any capsule, a thin layer of fascia just above the prostate, maybe called a prostatic fascia or whatever it called. There is a lot of nomenclature differences, and the rest of the thing is a levator fascia or a endopelvic fascia, which makes an outer compartment. And inside this compartment, there is that's called periprostatic fascia. There are multiple layers, veins, nerves, etc. Most of the structures in the abdomen have a blood supply from the posterior. The aorta and everything will be posterior. So when they supply into the pelvis, they come from posterior lateral surface. So most of the time, the blood vessels, etc., go in this direction at the posterior lateral surface of the prostate. So we have an outer covering, we have a prostate lying inside, and we have multiple layers or a compartment with multiple layers of smooth muscle or fascia, whatever you call it, interposed with veins, nerves, and the blood supply, etc., coming up in this compartment. So this is what you should understand about the fascia. So let us come into the detailing again it later. So if you look at prostatic fascia, there's so much of confusion in the nomenclature. You call it as endopelvic fascia, which was a parietal layer of the endopelvic fascia, which is called lateral pelvic fascia, superior pelvic fascia, parietal pelvic fascia, levator fascia, outer layer of periprostatic fascia, or parapelvic fascia. All these synonyms in the literature. And the second thing is a visceral pelvic fascia. That is what is covering onto the prostate. It is a visceral endopelvic fascia, which was there. Prostatic fascia, inner layer of periprostatic fascia. So there's so many nomenclatures. What you need to understand is there are two layers of fascia, one covering the prostate, another covering the parietis, and that is the levator ana. In between, there is a compartment with multiple small layers. As the prostate develops over a period of time, in the past 60 to 70 years, depending upon the growth patterns, these areas of fascias start developing. And a denunular fascia is nothing but a rectovesical septum, which happens in between during a urogenital sinus development. So look at I'm again emphasizing on periprostatic fascia. This is an endopelvic fascia which is there. This is a prostatic fascia which is there, and in between there is a compartment which contains a neurovascular bundle, blood vessels, etc., etc. So the endopelvic fascia covers onto the lateral pelvic wall, covers onto the prostate, and goes onto the other side, and lateral pelvic wall again. And this is a thin layer of fascia. This prostatic fascia is not as big as shown here. It is only depiction. And the rest of the thing is a compartment in between, which has got multiple layers as well, you can call it. And a denunular fascia, which separates it from the perirectal fat. So this is about periprostatic fascias. If you look at the periprostatic fascia in a microscopic level, let us not talk about intra, extra, nothing. Don't bother about it. There is a levator muscle. There is a levator fascia, that is a parietal pelvic fascia, which was endopelvic fascia, which was there. And there is a thin layer of the prostatic fascia around the prostate. That's not a capsule. And then there will be veins and nerves and little areolar tissue and the vasculature, neurovascular bundle lying existing at this point. And posteriorly, there is a denunular fascia. So this is a compartment which we should understand in much more in depth. So if you look at this, that's a levator, and the levator fascia or a parietal endopelvic fascia, and it's a multi-layer periprostatic fascia which is existing. So this is what we are looking at, and this is what we want to exploit it. Why does it develop into multiple layers? Prostate never develops. When the neonate, there is hardly any prostate. As the time passes by, there is multiple areas of increase in the size, which crosses some amount of compression to the periprostatic tissues. So you will find some sort of a layers which are going to develop. What is this extrafacial, interfacial, intrafacial? It's all confusion which is there. You see, everybody has got their own way of explaining this sort of a techniques. What they do entirely means is, if this is a prostate and this is a levator muscle and this is the incremental nerve sparing that can be possible by going into these planes. Going very close to the prostate is intrafacial. Very away from the prostate towards the levator area and taking out all the nerves is extrafacial. And incremental nerve sparing if you go in between the lines, etc. So you should understand only two things. Number one is extrafacial without nerve sparing. One is extrafacial with nerve sparing, a little nerve sparing. One is intrafacial, which is sparing all the nerves, and rest all is incremental depending upon the anatomy existing there. You can't plan it and go. You need to read the NMMR anatomy, which side of a nerve preservation you want to do, which you need to see, and then go ahead with it. So let us come to the neurovascular bundles now. Everybody talks about anatomy. This picture, I think everybody would have seen. There is a pelvic nerve plexus and there is a pelvic nerve neurovascular bundles on the periprostatic area, and the anterior nerve fibers onto the prostate, and these things going down into the urethra, paraurethral region, and going back into the pelvic floor, etc., and into the cavernous bodies. So if you look at the levator muscle here and the levator fascia here, and the prostatic capsule here, or a pseudo capsule, whatever you have here, and all these things are peripelvic or periprostatic fascia with inner blood vessels, nerves, and some smooth muscle elements and that nerves. So distribution of the nerves happens right from the periprostatic, the prostate capsule, right up to the area of the levator ani muscle. So all these areas is completely studded with nerves. So nerves exist in every level, whatever is there. So you need to understand the nerves are there all around the prostate, which is depicted very clearly. And then along with it, the nerves will descend para-urethrally into the, this is what we are talking about every time. But we forget one thing is this. So when you preserve here and you damage here, the result is going to be the same. So preserving these nerves also, which go away from the apex of the prostate into the pelvic floor, is also ultimate importance to preserve them. So there's no point preserving big bundle and damaging it here. So nerve preservation. So this is what we have been talking about. If you are close, you're there very close to the prostatic capsule, you say that it is intrafascial. So what you are going to cut is the small vessels and nerves which come onto the prostatic surface. They are going to be divided. But if you save the prostatic fascia and go in between these layers, that is called intrafascial, so that you preserve a little more amount of nerves. If you go away from the endopelvic fascia, away from it, and then you cut away everything, that's going to be extrafascial. So the nerve sparing is going to be divided into 3 patterns in some technique. Why this thing has come? Because everybody presumes that all the nerves are there in the posterior lateral neurovascular bundle alone. But it appears that these nerves are being distributed even onto the anterior surface also. It forms a hammock, as it is clearly seen here. It forms a hammock on the either side of the prostate too, and the base of the prostate. So you need to preserve as many possible if you really want to preserve in that case. So if you look at nerve sparing in the radical prostatectomy, there's so many ways of doing it. We explained about into the fascial planes. Getting inside the prostatic, into the just next to the prostate is going to be intrafascial. In between the layers is interfascial, and going away outside the outside the endopelvic fascia is going to be extrafascial. At the same time, there's something related to neurovascular bundles, whether it's full nerve sparing, partial nerve sparing, but there is no way I can describe it by as Montarsi did. And the third one is going to be where Ash Tiwari has done it. Grade 1 matches to intrafascial, grade 2 matches to interfacial, but in multiple planes, and grade 3 and grade 4. Grade 4 is extrafascial, but in between grade 2 and grade 3, there are many ways. That is incremental nerve sparing, depending upon the disease on an MRI, depending upon the disease on MRI and what you want to plan preoperatively. And the last one is what Vipul have explained is landmark artery. The presence of a landmark artery on the posterior lateral surface, which is nothing but a descending branch of the prostatic pedicle or inferior vesical artery, which goes onto the posterior lateral surface, and that preservation of it or not preservation of it, it amounts to creation intrafacial or an extrafacial dissection. So there's so many ways of this nerve sparing. So what we are talking about is just next to it is going to be the intrafacial. In between the layers is going to be interfacial. Outside the layer is going to be extrafacial. At the same wise, when you look at Tiwari, getting into the next to the capsule of the prostate is going to be the grade 1 and grade 2, leaving the veins onto the prostate, and between the veins and the nerves and the rareal tissue is going to be level 2. Level 3 is leaving that area, and just in front of the levator fascia is grade 3, and behind the levator fascia is going to be grade 4. So these are all nerve sparing. But you should understand, all these things are to be decided much ahead in planning. It is not that you go inside and start planning. You see the prostate, where the tumor was inside the prostate, what is the relation to the periphery of the prostate, what is the relationship to in an MRI, how far I can go, whether you're going to make a positive line, positive margin at all or not, or if there is very near to the neurovascular bundle area, you go a little away and do an incremental nerve sparing, etc. And the grade of Gleason score of the disease. All these factors play a role in selecting what you want to select. So if you look at the lateral surface of the prostate, I'm looking at another point again here. The levator fascia, it is there. The prostatic fascia, in this compartment, you will see these multiple vessels which are going away. What is this inferior vessel plexus, which goes in here? It gives away the prostatic branches, and then it runs all across the posterior lateral aspect of the prostate. And that is called the landmark artery or the capsular artery of the prostate. So preserving that artery, that means you are preserving a lot of nerves along with it in the neurovascular bundle. Taking out that artery means you're taking out a significant number of vessels which are going to happen. You should understand when you see this anatomy every time, you see this small area which is lateral side, lateral aspect of the prostate. Anteriorly, you have lot of veins which are coming near deep venous plexus, deep venous complex, and which serves onto the anterolateral aspect of the prostate and descend down into the posterolateral angle of the prostate and goes into the deep veins. But there is some surface of the prostate which is bare. This area is lateral surface of the prostate. That means it is between the neurovascular bundle and the lateralmost edge of the deep venous complex. Sometimes the deep venous complex veins completely surround the prostate, but a significant area of the prostate is bare at one point of time. And why this is relevant, I'll explain you in the surgical video when we are doing it. Coming to this, we have learned about the planes, we learned about the neurovascular bundles, and we learn now about the sphincter anatomy. If you look at the anatomy of the perineum and in relation to the continence part, let us look into it. These are the puboprostatic ligaments, and the muscle which comes next to it is a part of the whole pelvic floor is a puboperinealis muscle or a pubourethralis. It is pubourethralis. A part goes onto the prostate called puboprostaticus, or a part goes into the onto the bladder that's called pubovesicalis, and a puboperinealis. This is the muscle which is going to be there. And this is one part of it. And there is a small compartment in front of this U loop, and this puboperinealis goes to the median raphe, which is the base of the transverse perineus muscles, and that divides the compartment between anterior, which is having the urethra, and the posterior, which is having the rectum. So this median raphe or a perineal body is going to be very, very, very significant. Why? I will come back to you. So this is a puboperinealis muscle. This is the puboprostatic ligaments, right? And this is a deep venous complex which are there. And at the same time, the nerves are distributed all around the urethra, which is very clearly depicted. So we see there is on the urethra, there is a urethral striated muscle component. And there inside that component, there are two layers. One is a circular and a longitudinal layer of the lissosphincter. So a smooth muscle element, which is circular out and a longitudinal inside, and a skeletal muscle element, which is with both slow and fast twitch fibers, which is there in the outer to that area. And outside that, there is a compartment with nerves and veins, and which is taking a shape again, a puboperinealis muscle, causing a U into and separating the compartment from the perineal body from the rectum. So this is anatomy of what we require for continence in the male. Let us come to the next. If you look at anatomy around the sphincter, what we call it as a sphincter is this area. So if you look at that sphincteric area, which is the most important thing of the continence, let us look at these nerves which are going on the surface of the prostate, get into that compartment under the puboperinealis, and goes next to the urethra and go into the pelvic floor. This is what is into the cavernosus body. That is very, very important. So they spread all around the prostate, around the urethra. You can see that. So damaging them at this level also can happen inadvertently when you're not doing it correctly. So this is a puboperinealis muscle. What is this? This is the prostatic apron of the striated urethral sphincter. What happened in the embryology is said, anteriorly, the striated sphincter which was there existing here will grow onto the prostatic area. That is the prostatic apron of the striated muscle sphincter. And that is a striated muscle which is there in front of the urethra here. So there is a skeletal muscle which is going onto the prostate, and there is a skeletal muscle which is coming to the urethra. That's a striated sphincter of the external urethral sphincter. And the rest of the skeletal component is going to be under volitional control, is going to be this puboperinealis muscle, which takes a U across. And the common insertion for that is going to be the perineal body. Into that is the circular fibers, as I said, and the longitudinal fibers of a lissosphincter, which surrounds the urethra all around, right up to the bladder neck. This is anatomy around the sphincter area. So what happens in a continence? What is that makes continence? Suppose the patient underwent a radical prostatectomy, taken out the internal sphincter. So how does this membranous urethra, which is there between the bulb and the prostate, can create a continence? There are two things which are going to be necessary. Number one force is going to be a puboperinealis muscle. Contracting of puboperinealis muscle pulls the muscle in the perineal body this urethra towards the pubis and close the pubis. That's number one. Number two is the skeletal sphincter, which is covering the urethra. If it contracts, it is a horseshoe-type structure which is inserted into the perineal body. I'll go back into the previous slide. If you see this, it's a horseshoe-like structure which inserts into the perineal body. And if that contracts, what will happen? It pulls down the urethral walls, coapts the urethral walls posteriorly. So there are dual forces which happen in a continence. One force is pulling the urethra towards the pubis, and one force which is pulling the urethra towards the perineal body, so that the compression happens and existence of a lissosphincter inside, a smooth muscle sphincter inside, which gives continence. So these are the three areas of continence which will happen when there is only membranous urethra leading to continence. But for all these muscles to act, these skeletal muscles to act, you require an intact neurological factor. So it is not only preserving the puboperionealis muscle, but also preserving the external urethral sphincter skeletal part and the perineal body into which it is attached, and the nerves which supply around that urethra is essential to create a complete good continence. So we need to preserve the puboperionealis, which extends onto the detrusor, which extends onto the prostate, which extends onto the urethra and towards the pubis. And we need to preserve this external urethral sphincter, which is a skeletal component, which is a horseshoe-like thing, which is inserted into the perineal body. So contraction pushes the urethra backwards, and the lissosphincter. The longer the lissosphincter length, the better the continence, which is a smooth muscle contraction, both circular and longitudinal, and the nerves which supply these areas by preserving the nerves across. So all put together leads to continence. So how do you maintain the continence in these patients? So there are so many ways which we explained, but one thing fundamentally it is true. So these three measures, that is maintaining the puboperionealis, maintain the external skeletal component of the external urinary sphincters, length of the urethra, and preserving the nerves, all put together logically should be able to give a better continence. There's no doubt about it. So how do you try to preserve this continence? So other things which have come into place is techniques with preservation of radius space, bladder neck circular fibers. They may add to the confidence. That's what I said. Nerve bundles we agreed upon. Puboprostatic ligaments preservation. Deep dorsal vein complex also, it seems. Maximum urethral length preservation. Of course, we can understand that. Endopelvic fascia and preserving that detrusor apron which covers onto the prostate also. All these things have been found to be the techniques to preserve having a better continence, out of which few have become definitely thought to be logically appears to be definitely add to the continence. Technique of reconstruction, anterior suspension of the bladder and the posterior urethral reconstruction. What is there anterior to the urethra? What is there posterior to the anastomosis is being reconstructed by Rocco stage, renal fascia reconstruction, endopelvic fascia preservation, etc., for a better continence. All put together definitely makes a better continence. But how can it be achieved? That can be possible only when you understand anatomy and try to see that anatomy on the table when we are doing it. Let us look at preservation of the sphincter in this area. We are looking at external urethral sphincter area, and we want to preserve the sphincter in this area. By having understood that anatomy, if this is going to be anterior fibromuscular stroma of the prostate, if you really want to do preserve as much as urethra as possible, you have to take the surgical plane just below the deep venous complex to start with. And number two, there is a skeletal muscle component which comes onto the prostate. Usually, if you tie it and divide it here, you lost that complete sphincter here and that skeletal component here, both are lost. So that adds every millimeter in this area adds to the continence. Try to understand. If you read it, see this again. This is a smooth muscle component of the internal sphincter, which goes right up to the bladder neck. And this is the skeletal muscle component covering a part of the urethra, intraprostatic urethra, part of the prostate on the surface of the prostate, and the puboperionealis muscle, which we are talking about. So look at this. First step, Second step is going to be after reflecting this venous plexus, you reflect this part of the apron which is onto the prostate. That's the apron which is reflected here. And now you want to preserve this part of the skeletal muscle which is inside the prostate, and that is also can be possible. That's also can be possible by retracting the prostate and trying to expose this part of the urethra which is intra to the prostate. So after you divide it, you ultimately end up in saving that apron, saving that skeletal muscle here, and having a larger length of the urethra with a lissosphincter which is intact. That is a smooth muscle which is intact. So this is the way to preserve the sphincter. Which is it possible on the table? I think it should be possible. When anatomically they are all different planes, in which case it should be possible. So if you look at in the other direction from upward downwards, this is how the DVC, this is what is going to be the shrunken US apron, and this is going to be the skeletal muscle, and this is going to be circular muscle and the longitudinal fibers which are there inside the urethra. So this is how the depiction of the anatomy looks like. The same thing which is seen on the robotic picture when you look at it, which we'll see, which I'll be able to show on the table. Like it is a DVC here and the rhabdosphincter apron there, skeletal sphincter part and the smooth muscle part here. So we'll see it on the during the surgical video also. You should understand why MRI is important is understanding the anatomy of the look at the prostate. It can be like this, it can be like this, it can be like this, it can be like this. How do you plan your saving of that urethra is going to be seen much before after understanding it in MRI. There's no point without seeing this and you are trying to preserve as much length as possible. No, try to understand it a little ahead in advance. Anterior and posterior supports. This is one thing which has become very famous of late. Let us look at anterior and posterior supports. We have been talking about an anterior detrusor apron. See this? This is a good anatomical picture. This is the detrusor muscle. This is the prostate. And this is the detrusor apron which covers the prostate. At the same time, this is a deep venous cord. This is the veins in the DVC. And this is the skeletal component of the urethra, which covers onto the prostate. So there is an apron anteriorly, there is an apron inferiorly, anterior superiorly and inferiorly. This is the detrusor apron, and this is the skeletal muscle apron of external urinary sphincter. So that's a support with the puboprostatic ligaments attaching this part vesical, prostatic, and this part of the urethra. You see, you try to understand when the puboprostatic, these ligaments were there when the child is born. The prostate is not even few millimeters, so it is not puboprostatic ligament. It attaches to the base of the apex, the bladder neck area. It attaches to the prostate and it attaches to the membranous urethra, and towards it goes into the pelvic floor. So this is a combination. Shall I? Sharma?
Yes, sir. We will talk to Navneet about the.
The recording has stopped, but the transmission is
Okay.
on.
No, there was a recording and stopped, so I just okay.
No,
That's
yes,
it.
it started.
Got it. So you see that when it was a neonate, it will be a few millimeters and a small puboprostatic ligament. But as the patient grows and the prostate grows, the same ligament goes towards the bladder neck and towards the prostate, and sometimes even right up to the ischium, towards the ischium or the pelvic floor also. So puboprostatic ligament is not a one single entity. It's a complex which is there existing, which is giving a support to the bladder and the prostate in this area. So we need to understand that part. At the same time, if you look at the posteriorly, the tough denunvular fascia, which is nothing but obliterated whatever septum was there, which was dividing the rectum and the urogenital sinus, and that is a tough structure which gets attached towards the to the perineal body or a median raphe, onto which all these muscles are attached. So you have a tough denunvular fascia posteriorly, you have a tough structure which is holding the prostate anteriorly, and then and the coverings onto the muscles around which are attaching to the median raphe, giving a compact area of keeping it attached in that area. So all these things are anterior or posterior supports. How do they matter when we do a radical prostatectomy? So what is that biomechanical instability once the prostate is taken out? What all can happen once the prostate is taken out? tension on the vesicourethral anastomosis from spontaneous urethral stump recession into the pelvic floor. Suppose you have a very short urethra. What will happen? There is a tension on it and the bladder is pushed down into below the pelvic floor. So there's no way this patient can be continent. There's no way you can be having a continence. So you need to have that stump above the pelvic floor for the bladder to attach. So there's no point attaching the anastomosis at the level of pelvic floor. So how do you retain the tension? You need to push it back and it will be retained inside, retained in that position. So that is one thing. Second thing is posteriorly deficient. This omega is going to be external sphincter, which is like omega, external skeletal sphincter of the external urethral sphincter is like omega. If there is damage to this median raphe and this omega doesn't really adhere to the median raphe, the contraction doesn't happen. So if you have lost that support in the posterior area of that median raphe or damage to the median raphe, and this omega shaped sphincter gets unsupported and there is an impaired contraction of the sphincter mechanism. Third thing, posterior bladder lies up unsupported. There is a lot of tissue which has been taken out. The seminal vesicles, prostate, everything is taken out. And the bladder neck which is there may get unsupported. It may get supported because the inner area fascia will get attached and etc. But there is a possibility of getting unsupported bladder neck. Fourth thing, anterior and lateral bladder. Because you are dropping the bladder anteriorly, the whole attachments of the bladder and the bladder getting retained into the pelvis, into the upper part of the pelvis is going to be lost. So all these support structures, we lose the posterior support. It may be descent here, urethral descent and bladder descent. If there is no anterior support, the whole bladder descent. If there is a tension, descent of the whole anastomosis into the pelvic floor. So creates this biomechanical instability. So when you see before prostatectomy, how the bladder was positioned, the bladder is stuck and it is stuck to the pubis band and the prostate is stuck here, urethra is into the part and there is a median raphe which is existing here which gives a support to it. But after radical prostatectomy, what is there? The attachment to the puboprostatic is lost. You may attach this Muller's ligament into the median towards the median raphe to the denulnar fascia. That's the only thing what is possible. Rest all can still be done. So before and after RP. You understand this anatomy? We'll go back to the surgical video later. So the posterior support, which has been commonly done. So if you see this longitudinal muscle of the bladder, which extends onto the prostate to certain extent posteriorly, will be very well seen after you take out the prostate or division of the bladder neck, which I'll show. And that longitudinal muscle can be attached to this median raphe and the denulnar fascia to give a posterior strong support so that the descent of the bladder, descent of the rhabdomatous sphincter doesn't happen. So that we are going to demonstrate. So this is one thing which has been very commonly being used. Say you call it as a Rocco stitch, but the functional detail of the Rocco stitch is basically this is the median raphe, this is the denulnar ligament, and this is the posterior longitudinal muscle of the bladder, all stitched together in so that they come across. So if you look at the anatomic restoration, looking at creating a suture line between the puboprostatic ligaments, arcus tendinous, and into the bladder, and the posterior suture line creating the denulnar fascia or a Rocco stitch, and this creating this decreasing the dead space so that both supports are clearly retained. So ultimately, the goal is going to be a secure vesicourethral anastomosis, maximize functional urethral length, restore the support structures, and prevent a bladder descent, minimize the damage to the urinary sphincter and neural supply. So this is the time I would go to the video. So we are going to a video of a 62-year-old gentleman who had a PSA of 7.2. On the right side, there is a tumor here, just posterior to the surface, and Gleason 3+4, 3 course on the right side, and the left side is absolutely preserved. So with this sort of a thing, low grade disease, low PSA, low stage, posteriorly placed, what should I do? I should think about intrafacial or interfacial on the right side and complete intrafacial on the left side so that I can save as many nerves as possible for a better continence. So let us look at, I'll stop sharing and start sharing my video across onto it. Okay, that's a video. Are you able to see? Hello? Are you able to get the...
Yes.
Right, I am playing the video now. Okay, right. So this is a clinical picture which I already discussed, and then now I'll go, sorry, it's fast forwarded, sorry. Okay. So I start with a posterior dissection always to make this clear anatomy. So I make an incision onto the peritoneum somewhere just below the vasal impressions on the peritoneum. You can see the vasal impressions onto the peritoneum and start. You see, if you look at anatomy here, I stay close to the peritoneum. The structures anterior to the peritoneum, sometimes in a fatty patient, you may have a little fat with the peritoneum, but most of the time there's hardly anything. And you directly get into a compartment which is covering the seminal vesicle and the vasa as a single compartment. And that is the denulnular fascia, which you see as a two-layer denulnular fascia, which is covering. This is one layer of denulnular fascia. Yes, that is the denulnular fascia, which is getting separated from the peritoneum. And that is the denulnular fascia, which is covering the compartment. So once you have done that, you know that you are able to create a thing, and then you go down, and that is the denulnular fascia. That second layer of the denulnular fascia, which is going to come in. That's a tough posterior layer which is there, and this is the denal area which is covering the seminal vesicle, which is thin, and we are trying to retain. So dividing that denulnular fascia will expose you to the perirectal fat directly. See that? You can see the perirectal fat directly. If you really want to save denulnular fascia, you need to go anterior to it, that layer. It is a complete intrafacial, posteriorly. But I don't want to do that in this patient because the tumor was posterior. So I try to go as towards the rectal fat on the right side and towards the not away, a little away from the rectal fat on the left side. I can retain some fibers of denulnular fascia on the left side, but not on the right side. See this? You see on the left side, I'm trying to retain, but I may retain some amount of fascia. But on the left side, I'm exposing the fat. On the right side, I'm exposing the fat completely. So you start dissecting it again. On the right side, I'm staying close to the fat and dissecting the seminal vesicles. So I would say all the time, you do as much dissection as possible when you do it posteriorly. This is the 30-degree up on a robotic surgery. So that will expose you right from the behind. You are behind the prostate now. This is on the left side. I'm staying on the surface of the denulnular fascia, trying to preserve some amount of denulnular fascia for a posterior reconstruction here. But on the right side, I'm trying to stay away from the denulnular fascia so that I may not leave anything there. So that's a denulnular fascia, one layer which is there, which I am trying to preserve on the left side. So that's a prostate. I'm not there behind the seminal vesicles any further. In fact, what you do as a Redgius sparing is, this is the plane what you start dissecting in a Redgius sparing. So you try to be on the surface of the prostate, and this is the denulnular fascia which is being saved on the left side. On the right side, you see that we can go right up to the base or even the apex of the prostate. That's on the left side, which I'm going towards the apex of the prostate. That's on the left side. And on the right side, I go right up to the lateral wall of the prostate here, because I'm not dissected in the denulnular fascia, I'm outside. So I'm going, this is the veins on the lateral aspect of the prostate, and that is the levator muscle which is getting exposed. So I'm quite close to that lateral pelvic fascia and the perirectal fat. This is on the right side. So I think I've done a fair amount of dissection posteriorly, which gives me an edge in doing some sort of a nerve preservation. Previously, we used to do a clipping of the vas, which we don't do, but you try to divide the vas as laterally as possible, because you should expose not the body of the seminal vesicle, you should expose the tip of the seminal vesicle or the lateralmost portion of the seminal vesicle where the seminal vesical artery is there. So going towards the lateral aspect, but don't go too lateral that you're damaging the ureter, because next to it is going to be ureteria. So don't go too lateral. So you need to hold that tip of the seminal vesicle and start. It's some sort of an enucleating the seminal vesicle from it. Sometimes we used to clip this artery, which was supplying the seminal vesicle, but of late we don't do that. We just do a diathermic coagulation and division. You get into the same plane onto the other side and start creating the same plane on the other side. There's no point separating the two seminal vesicles separately. Let it be attached into the midline. There is no point separating it. It doesn't give you any advantage. So just think that they are a single unit and start dividing. So as laterally as possible, that expose the tip of the seminal vesicle and then start enucleating the seminal vesicle. Stay close to the seminal vesicle. There's no point to be very far. But one thing is, you need to go to the right up to the base of the prostate. Don't go very away, because that makes your bladder neck incision much more easier. Posterior bladder neck incision much more easier. So that is a division which has been done, and the same lateral dissection what is being done on the left side of the patient now. So next, close to the prostate. That is it. So this is a posterior dissection which is complete. Now come to the dropping of the bladder. Never go to the midline. Come to the next to the medial umbilical ligament and then start dividing. Then go anteriorly. See, even then, after this, you see, you miss the plane here. You see that in the same fold case, I missed the plane. I went into a plane deeper to the aponeurosis. See that? See that? That's a mistake. That's a mistake. So you need to correct it immediately. Say that there is a specific plane between the anastomosis. There's no need to go behind that, and there's a specific plane between it. And the best way to achieve it is dividing that. You pull the bladder. You see this. This is wrong. And pull the bladder, and you see that empty area where the fascia is. The peritoneum is very well transparently seen, and you start dividing it. And lateral to medial will be a better idea rather than coming from upward downwards. Come lateral to medial. See this? Come to lateral to medial. That's it. You'll be able to create. And there is I tell you, the fat which is attached to the abdominal wall is different. See this? That is different. And the fat to the bladder is different. That's a plane of dissection between. Majority of the times we stay very close to the abdominal wall and thinking that we will open the bladder, which is not correct. Don't stay very near to the abdominal wall. Stay away from the abdominal wall and then leave that fat which is stuck to the abdominal wall with the abdomen itself. And there's a beautiful plane which always exists between that, and you enter into that plane and start growing after having a traction. And then now you enter into the space of Regius. The moment you see the pubis here, you see the Regius space, which has got a different areolar structure when compared to what you had at this point of time. This areolar structure, you pull that area, you'll see only areolar structure. You pull the area between the bladder and the anterior abdominal wall, you see two fascial layers separating. So that's how you identify when you open the Regius space. When do you stop? How much bladder you need to dissect? On laterally, number one, you need to divide the peritoneum between the two external rings, and both obturator foramina have to be exposed very well. So that is how you decide how much you need to dissect. That's an obturator foramina which is seen very well. And now, after being done, that you need to excise the periprostatic fat which is going to be there. So now that exposes our endopelvic fascia, which covers the lateral pelvic wall and covers onto the prostate and goes on to the other side of the pelvic wall and exposing the DVC complex here underneath and the puboprostatic ligaments. So having excised the defatting of the prostate, you see that puboprostatic ligaments. I've been telling you, I just stopped the video. Again, I'm telling you, see this, puboprostatic ligaments are not onto the prostate, but they converge towards the bladder neck. This is a point at the time of embryology. When the prostate starts growing, there is some part which comes towards the bladder neck, some part which goes onto the prostate, some part which goes back as a Muller's ligament. I'll show you that once we start dissecting. So this is endopelvic fascia, puboprostatic ligaments, and the bladder neck. Two puboprostatic ligaments will converge, and that is the best way to identify where the bladder neck lies. So that's what I just wanted to show. That's what is the bladder neck. So now we are looking at the dissection between the two layers of potential layers between the parietal layer of endopelvic fascia and the layer which is covering the prostate under which the vessels, everything are there. See this? That's a potential layer. That's a parietal layer of the endopelvic fascia. And what you see on towards the prostate is a visceral layer. So there's a potential space which exists, which was there existing at one point of the time. But as the prostate grows, this space becomes smaller and everything becomes together. So that's a potential space which exists. And you can see that's arcus tendinous fascia pelvis. And that is the levator vena fascia, the endopelvic fascia, which is covering the levator venae. And you see this. This is next to the bladder neck. I'm dissecting in next to that area. This is the bladder neck. And you see this prostatic pedicle, which is going to be, that's a conjunction between the bladder and the prostate. You can see that. And the whole thing, the posterior dissection, what we have done gets exposed. This is the prostatic pedicle. This is the neurovascular bundle here, and the lateral pelvic fascia and the fascia covering the layers of the prostate. So I'll show you the seminal vesicle coming up this area itself. So what we have dissected posteriorly is coming up very well, and that's the seminal vesicle which is going to cover. So if you look at this anatomy, it appears it appears that the endopelvic fascia, which is covering the levator ani, is separate. The fascia which is covered, facial coverings on the prostate is separate, and this contains the neurovascular bundle, and this whole thing contains the neurovascular bundle and the prostatic pedicle here, prostatic pedicle which is there. So I continue in the same direction. This is the compressed facial layers which form the puboprostatic ligaments. I divide the puboprostatic ligaments which are attached to the prostate, but retain that part which is there towards the levator ani. I don't need to divide it completely. I leave that arcus tendinous fascia pelvis continuation towards the puboprostatic ligaments, and I go in between. See this? If you cut onto the fascia, you go onto the muscle. That's not the facial layer which I want. I need the fascia to be attached onto the muscle. So that's a layer. What I'm talking about, below the levator ani fascia, which is there covering the muscle, we leave it towards the muscle. We leave it towards the muscle, which is separating off. And this is the veins and the nerve complex, which is there lateral to the prostate. That is being covered away. See this? This is the puboprostatic part of the muscle, ligament, which is coming out, which goes onto the prostate. And see that the thin layer, which is there covering this periprostatic tissues, and that is the levator ani muscle, which is being dissected away towards the levator ani. So we are dissecting between that plane of endopelvic fascia and the periprostatic structures and creating a space in that structure. We are already dissected posteriorly. That part is already seen here. So this component, which is very well seen. Now I'm talking about that lateral part of the prostate, bare area of the prostate, which I need to identify so that I can think about saving the neurovascular bundle there. So that is the layer, bare area of the prostate where the veins are not there. This is arcus tendinous fascia pelvis, levator fascia, and the periprostatic tissues here. The only thing you need to understand is there are multiple veins. So dissection into that veins, there is a plane existing in the surface of the veins, but sometimes they get divided. See this? This is another facial attachment, puboperinealis muscle I was talking about. See this? This is a puboperinealis muscle with one attachment going towards the prostate, and that is a puboperinealis muscle which is encircling the urethra here. Encircling the urethra here. That is what we are talking about. That's a puboperinealis. Saving this muscle is most essential in creating good continence. That's the lateral surface of the prostate. I'm dividing that facial layers there. That's a bare area where I don't find any vessels there. So that is a bare area which I'm dividing. So I divided that layer and then going on to the surface of the prostate, and whatever vessels are there on the lateral to the prostate, I'm taking them back onto the pubic bone towards the pelvic wall only. See that? These blood vessels which are there on the prostate, I'm taking them off completely. Some veins are still there on the prostate, but majority of this is the bare area, I'm taking them off. So this contains the neurovascular bundle here. This contains, you can see that landmark artery which is pulsating here. So this contains the neurovascular bundle, which goes, and the whole bundle which go towards the urethra. This is a puboperinealis muscle, and that is the neurovascular bundle. It's a prostatic fascia, which is the thin layer which is covering the prostate. Very thin layer which is covering. Sometimes some vein also can be there. But still, there is a potential plane which can exist and can be separated across. And that's a landmark artery, what I was talking about. That's a landmark artery. So we see this vascular pedicle coming into the prostate, and a descending capsular branch going towards the prostatic lateral surface and going towards the urethra on the laterally of the urethra, and accompanied by a large chunk of neurovascular bundle. I've done a fair amount of dissection on the lateral side of the right side. I can still make out one more layer here and take it out, which anyway, that I'm not keen on now, but that dissection is good enough. So I'm trying to, that's on the right side that is completed. Now I go on to the left side. Left side also the same. The two layers of the endopelvic fascia, I'm able to create a plane between the two, and then try to divide that attachment between the two layers. And again, I can dissect the pedicle of a neurovascular bundle, vasculature of the prostate next to the bladder neck area. And what I see in front is going to be a prostatic pedicle here. And I'll go into the same area, what has been dissected posteriorly, and the seminal vesicles are exposed here. The same area, longitudinal muscle that's a neurovascular bundle on that side. Anyway, that is only for demonstration. I've done it. So I create a plane between the two layers of the endopelvic fascia and try to create a compartment, or all the things which are there towards the prostate, and enter into onto a bare area to do a complete intrafacial dissection on the left side. So that is the veins which are there towards the prostate. That's a deep venous complex. Let it stay there. And that's a levator fascia which is there. And we are trying to dissect between the veins and the lateral pelvic fascia and exposing that area towards the neurovascular bundle and the lateral prostate of the prostate, lateral surface of the prostate. That's a lateral surface of the prostate here. You still go ahead and it will come to neurovascular bundle area. See that? So many veins on the lateral surface of the prostate. I'm going to the base of the prostate now. And that is the lateral surface of the prostate, which is a bare area now. So the veins are still there. I can take a bare area somewhere here and try to preserve that veins which also are there posterior laterally towards the prostate. So this is the puboprostatic ligament. And I'll show you that that is going to be the prostate which I'm looking at. So levator fascia, periprostatic fascia, there are some veins here. Here I want to select into an intrafacial plane. So I need to create an additional plane. What I'm cutting is the Muller's ligament, which is the attachment to it's an extension of a puboprostatic. See this? I'm getting into the layer now. If I continue like this, I still believe that I've done an interfacial dissection. But if I'm going deeper into it, I'm trying to do an intrafacial dissection. So trying to create a plane between those two layers and keeping a layer and some veins and nerve bundles posteriorly is a basic idea of an intrafacial dissection. So I'm on the surface of the prostate here. There are some small veins there and trying to create a plane on the surface of the prostate and trying to preserve all those veins lateral to the prostate posterolaterally. And that is the nerve bundle, what you're going to see. Multiple veins and a nerve bundle. See that? This is their area of the prostate which are seeing, and we are trying to create as much as possible. And that is the nerve bundle which is going to be there. So having done this now, I have done a fair amount of dissection. Now I go towards the urethra. That's a little amount of division what we require to proceed. Okay, I go towards the apex of the prostate. So dissect the apex of the prostate. You know how the apex is there on an MR. So you continue to dissect and try to get away. This is the periprostatic tissue which are there, trying to get away all the tissues next to the prostate to the lateral pelvic wall only. So that is the apical dissection, what is happening. Now you see that puboperinealis muscle coming up. This is the periprostatic fascia, which contains the veins, neurovascular bundle, and then that's a puboprostatic muscle, which is being divided. That means the same puboperinealis which goes onto the prostate, and a Muller's ligament here, which goes in there. See this? That's a puboprostatic muscle there. And I'm going to expose the urethra now. That's going to be the urethra here. And this is the deep venous complex, and that's going to be the urethra there. It's a covering of the puboperinealis over the urethra. And I'm separating that apex away from that muscle. A little blunt dissection there, that's apex which is being covered. And this is the puboperinealis there. So the apex is completely dissected. So stay close to the prostate, and that amount of dissection will expose the apex completely. That's the exposure of the apex completely, and that is going to be the median raphe below the sphincter area at that point. So preserving all those structures is very essential for a better continence. So I think that is enough for on the left side. That's on the left side. That is it. And you can see that the urethra is very well exposed at this point. And this is the median raphe there, and this is the puboperinealis muscle. I don't know whether I will be talking about puboperinealis all the time, but it's essential. So puboperinealis, that is the deep venous complex, puboprostatic ligament here, and that's an apex which is exposed. So all structures what we wanted to save are completely saved here. So having done now the bladder neck incision, that's an apex, and the bladder neck incision. Every time we go here, but have you done the dissection on the lateral aspect? Either you can divide here to understand where it can be. This is the levator fascia which is there in the puboprostatic fascia. Identify the bladder neck by gently pulling on the catheter, or the puboprostatic ligaments which are there towards the bladder neck, which can expose the bladder neck. I can divide it there. But the better option is going to be, having identified this window here already, I go towards the junction between the bladder and the prostate and expose into the small areolar tissue which is existing. You see, the bladder and prostate are next to each other. There is intermingling of the muscular fibers which go between the bladder and the prostate, but there is some amount of fat and areolar tissue which also exists between the bladder and the prostate. So you need to get into that area. I'll show you. At one point when I'm dividing, you see that white transparent areas here. That itself means that you are in a correct plane. If you're not in a correct plane, you don't see the transparencies coming in between. These transparencies mean that you are in a correct plane. You are separating the muscle only. You're not getting into the prostate. The same thing is attached on that side. So having done this, I got a window on the other side also. So the same incision will continue on the other side and attach to that window. So that is the window. I come up again. So the neurovascular bundle is separated. The posterior bladder, posterior wall of the bladder neck is yet to be divided. And we have made a window already, which because of the posterior dissection. And this is what we are trying to, this is the longitudinal, the muscle of the inner muscle, sphincter of the bladder neck, which we are trying to save. This is one way of preserving the continence. So that's a bladder inner, that's a division posteriorly, which is being done. Finished almost. It's almost. And now we divide and preserve the circular muscle as much as possible, so that this adds to the continence. So the circular muscle and the longitudinal muscle of the bladder neck, which is also a sphincter at that area, try to preserve. Possibly, yes, it may add to the continence. So once you do it, you'll be able to see that the catheter is being taken out. You see the bladder neck very well. Don't take it, don't cut it off without understanding the bladder neck posteriorly, because you may have a median lobe. But that idea you can get onto by having an MRI. I always avoid this mucosa, because once you divide, when you preserve the bladder neck, the whole mucosa gets into the bladder completely, and you will not be able to see. So I preserve that, and then so that there is a slight eversion of the mucosa, which makes my suturing much easier. So that is an eversion. And the same thing which is done in the posterior bladder neck also. I can a little fast forward it, because the same thing is being done here. Yes. So having done that, having divided the posterior bladder wall, everything will come in. So what you see now is a prostatic pedicle. I need to thin that prostatic pedicle. Don't make a multiple clips. It's a thin. So what you see is a prostatic pedicle, and there is what is the descending branch which goes all along the prostate, which was already come out. It comes out much ahead, not next to the prostate. It comes much ahead. So the prostatic pedicle is going to be clipped and divided. So what you left it is all the tissues into the anterior side of the prostate has come out, and the deep venous complex, which is draining into the prostatic pedicle area, is going to be divided and it's going to be clipped. So that's a bare area of the prostate what you have opened up. You are thinning up the pedicle and you are clipping the pedicle. There you don't need more than a clip or two to get that maximum 2 clips which are necessary, and you are going to clip it and divide it. I can still get into a plane next to the prostate here also, but it is not necessary. It is already separated. See this now. Now you see a bare area of the prostate here, and there is some amount of attachments of this pedicle. You don't know whether there is any veins still or arteries which are there. This is a landmark artery which is supplying onto the side of the prostate, and then goes towards the obturator artery, and I say close to the prostate now. Not very, very close here because it's on the right side. Not very, very close. I may leave a little amount of tissue because that's the side where there is a tumor. So I try to divide. I may not do any clipping because I don't know where I will be clipping. So I leave a little amount of tissue onto the prostate, little amount, not bearing the prostate completely, and some amount of tissue which is going to be retained. But fortunately, I could retain that capsular artery much ahead in advance. It was not just running next to the prostate a little away. So that is the way I do a little. It's not completely intravenous, I would say, it a little away from it. There is some amount of tissue on the surface of the prostate, some layers of the prostate. And this is the area of the tumor at this area. So this is multiple veins or small vessels, which I don't want to buzz. And that is the tissue which I'm going to separate it away from the apex of the prostate. So that's a separation, a blunt separation. Most of the time there is any. See, this is a puboperinealis muscle. This is the puboprostaticus. That's an extension of puboperinealis onto the prostatic area. So I divide and preserve as much muscle as possible. And then that is the urethra inside. And that was a small arterial twig which is coming towards that area. But I don't want to go very close to the prostate. I'm leaving a little part of the tissues above and then separating that tissue. So the apex of the right side is already completely exposed. So I'm staying a little away from the prostate. There is a layer still existing. Small veins are already existing. So I'm just going away from the prostate. So that is anatomy on the right side now, what we have dissected after dissection is concerned. And that is a median raphe getting exposed there. Right? That's a DVC, puboprostatic ligament, and that's a puboperinealysis, puboprostaticus, and that is going to be there that way. Right. So that's done. And then we'll go on to the left side. Leave some tissue towards the prostate because the tumor was there in the posterior aspect in the apical area only. Apex, neurovascular bundle, puboperinealysis, and the DVC. So we go on to the other side of the other side dissection now, which is already done, and the same thing which is going to be exposed. And I don't think I'll repeat the same thing. You need to again I'm saying you need to decrease the size of the pedicle to the minimum. In the posterior aspect, you hardly have any vessels. Most of the vessels are stay in the posterior lateral aspect. That is the point where all the vessels are going to be there. So divide it close to the prostate because I'm trying to go as close to the prostate as possible here. Divide it. And there is this. You see, this dissection was already done by me before itself. Laterally, I've gone quite laterally. So I went very close to the prostate and I'm exposing the surface of the prostate. The neurovascular bundle has gone. So I go back into the same direction and dissect into that direction so that I try to retain as many nerves as possible. And you can see my instrument coming back. That's my instrument coming back. So the whole prostatic pedicle, if I stay very close to the prostate in this area, the neurovascular bundle, where the main vessels going to the neurovascular bundle is going to be intact. And I'm going to take care of only the prostatic supply per se. So that's what I'm doing now. I'm staying close to the prostate. And that's the muscles of the detrusor only. And I'm going to thin the thing and I'm going to come back again and say that what is the actual pedicle. This is the neurovascular bundle which I want to save there. You see that? That's a neurovascular bundle which I need to save. That's the raw surface of the prostate here. So the whole tissues which is next to the raw surface of the prostate has to be retained because this is on the left side. We are doing a complete neurovascular preservation. So decrease the size of the pedicle. Make a one clip. These two clips are enough to finish it off. And if something bleeds, we can clip it later. And that is it. So that is the pedicle of the prostate which is completed. And now you see the neurovascular bundle which is separated, which is completely attached onto the surface of the prostate. There's one more still a vessel, this is NVB, and there's still a small vessel appears to be there. Possibly I may need to give a small clip there. I'm trying to get it down if not necessary. I try to put it or a clip, or I think I clipped it and it was divided. So I'll get into the apex of the prostate. That's the clip which is already done. I go to the apex of the prostate and see the same thing what I've dissected onto the left side. So now I go back into the division of the, I don't think I need to show this again, possibly a little fast forward. Yes, I'm going to go for the division of the disc. I'm going to hold the DVC like this. Don't just go on dividing it. Otherwise, you'll end up in dividing into the prostate also. Just divide it. Don't suck, just irrigation. The more you suck, the more it's going to bleed. So once you are dividing it, you're on the surface of the prostate now. Get into the DVC and then little closer towards the prostate. Once you reach towards the apex, you go towards the prostate now. Now you see what I was showing in the previous pictures. That's apex of the prostate. That's a Muller's ligament which goes towards the pelvic floor and towards the median raphe, and that is going to be the division between this thing. And now you will see the apron of skeletal muscle onto the prostate. The apron of skeletal muscle coming onto the prostate. What it bleeds is still the DVC. What is bleeding is still the DVC. That's the small vessels which are coming out from the DVC. Divide the DVC. Divide it, and that Muller ligament which is going to be there, and external. This is external sphincter, external urinary sphincter apron, which comes onto the thing. That's the surface of the prostate, and now you see the apron coming onto you once you decide it. Once you divide it, that's the surface of the prostate you're on. And what is this muscle? What you are seeing here is nothing but the apron which comes onto the prostate from the external urethral sphincter. It's a skeletal sphincter which is going to be there. And reflecting that apron will expose you to the urethral muscle there, urethra there. That is the urethra, what is going to be seen. So all this area, what is seen here is the apron of the external urethral sphincter, which comes onto the prostate and which aids in continence. So that is the external urethral apron, and that is the division of that's the external urethral apron. Small bleeder there, okay. And this is the circular layer of the urethra which is getting exposed now. So I stay close to the prostate on the left side. I go a little away from the prostate on the right side because that's an apical tumor. So I'm going to strip whatever the tissues there inside the urethra a little bit. I don't want to do too much because of an apical posterior tumor, but anyway. But that's a circular layer. So I'm trying to get that as much as possible on the left side, at least, to create amount of length to the membranous urethra and in the continence. So external urethral muscle, which is skeletal muscle, which is apron, and this is the inner part of the circular muscle. So now I start dividing the urethra. Okay, I'll just fast forward it. Yes, that's a urethra, and that's a outer circular layer and the internal longitudinal layer which is coming up. After dividing it, it's only the urethral muscle which is going to be divided. After dividing it, you will see the posterior rhabdosphincter. That means the horseshoe thing which goes towards the median raphe will be quite evident now after dividing it. See this, the posterior part is already clear. We have dissected it. And this is the urethra, only circular part, and the longitudinal smooth muscle part which is there around the membranous urethra which is being divided. And now you see the skeletal component which is there posterior to it. That is the skeletal component which goes towards that is the rhabdosphincter which goes towards the median raphe, and trying to preserve that is going to be very essential. So this is the step where I take a stitch from the median raphe into the rhabdomyosphincter and keep it across on the other side. And the same thing I do it on the left side also, so that I use that as a Rocco stitch and get it into the center to give a posterior support. That's the left side. And the same thing I do it on the right side. Same thing I do. It is not urethra which we are talking. That's a rhabdosphincter which is there, and that is going to be kept aside for a period of time. Now I close the DVC which is there. Oh, I've divided the posterior part and I'm closing the DVC. See, when you close the DVC, don't take this external apron along with the DVC. It's a very common mistake to take off all the tissue which is next to the urethra to get a better control of veins. It is not correct. You just take that part of the DVC and leave alone that EUS apron which is there around the urethra, and leave it there, and leave that suture layer for further. So the same sutures which have been placed on either side are taken to the denonular fascia and to the posterior longitudinal muscle of the detussa, and these two things will pulled up and come, and that causes that's a Rocco modification of a Rocco, whatever you call it, and that produces a posterior support mechanism for that sphincter and some amount of advantage to the rhabdosphincter, because the median raphe is still fixed and not damaged. So the same sutures are got in the midline, got into the bladder, and the anastomosis can happen with the urethra. So there's only one point which I wanted to emphasize during. Don't take all the tissues next to the urethra. Just take that urethral tissue only, which contains the circular and the longitudinal fibers only. Don't take the external urethral sphincter there. Don't take the puboperinalis muscle there. So by taking it away, you are going to lose a significant, see that I am avoiding that, and you are going to lose a significant amount of muscle for a better continence. So preserving that muscle around the membranous urethra, using that muscle only which is there in the mid of the circular muscle of the urethra is going to be of utmost importance. And I don't think there's anything much I need to add on this other than creating a similar thing. So posterior support is done. Anterior support is going to be, so after done with the anastomosis, I put the catheter later, I take out a catheter and I take out a catheter and replace the catheter again. So a good anastomosis means you should be able to pass a catheter after the anastomosis is done. There is nothing why you should be able to take. See this, the external urethral urinary sphincter, this thing is still intact there. So use that same DVC suture which was used, and then use it for the detrusor wraparound which was there anteriorly into the prostate and create an anterior support. The same suture can be brought onto the arcus tendinous fascia pelvis also. And the same thing, sometimes I do this flipping of the too much of a bladder flap is there. I just flip the bladder flap onto the detrusor itself. That especially in cases where a lymph node dissection is done, it will help in decreasing the lymphoria and lymphocyles. So I think that is the end of the surgery, and I think I'm open for the questions now.
Thank you, sir, for an excellent talk. I remember having talked to you once. I asked you, what is the role which you enjoy the best, because you play multiple roles. And you said you love teaching the best. And it was very evident because it was a smooth talk without any halts, as if there was a teleprompter in front of you and you were reading through it. Fabulous, sir. Fabulous.
Thank you.
Sir, one question which I would like to ask. What have been the difficulties that you have faced very early in your learning curve when you started doing robotic and laparoscopic radical prostatectomy?
Learning anatomy. Learning anatomy was the most difficult. I think we are all born, we are all trained and good surgeons. The only thing is, the better surgeon is the only guy who knows anatomy better. How to cut a tissue, you don't need to be taught. What to be used, no need to be taught. If you know the anatomy properly, we started to see, unfortunately for us, we have never been taught about this anatomy during our residency. We are not seeing this anatomy during our routine day-to-day surgical practice. We started looking at it only off late in a magnified view. Possibly in the next near future, the younger generation are much better surgeons than us because they can see the anatomy in a different direction. So what the basic thing what was happening is understanding and assimilating the anatomy, which according to case, every prostate is different, every case is different. So understand and assimilating that anatomy was a basic constraint in the whole laparoscopic and robotic era. So the moment you know it, rest of the physiology you know well, rest of the support systems you know well. So once you know it, I think you should be able to do it. Yes, Sanjay.
Yes, sir.
Yeah. Can I ask what is the, in expert hands today in India, what is the continence rate achieved at the end of catheter removal and at the end of 3 months and at the end of 1 year? Continence.
I'm not arrogant if I say my data, Sanjay, because let me not talk about, it's not a question of arrogancy. I'm looking at early disease, a localized prostate, 10 less than 10 PSA and everything, early disease. If I do a dissection like this and do a surgery like this, I expect this patient to be continent on day 1 itself. This guy should not leak if I take out a catheter. So it is happening in 30 to 35% of the cases in this sort of a selected individuals. Rest of the 30% will within 15 days, and rest of the 20% will take 1 month, and rest probably go up to 3 months. It depends upon patients, their skeletal structure, their abilities, degree, our dissection, and whether we are able to sustain this sort of anatomical supports, whether we could do that sort of a dissection as you envisaged before surgery. So we should be able to do that.
Sir, can I ask a question, sir?
Yes, sir. Yes, ma'am.
Sir, the prostatic artery which you ligated, if you ligate it closer to the bladder, prostate junction between the bladder and the prostate, there would be less likely chances of injuring the neurovascular bundle, so that it dips downwards.
You see,
Is
there are
that
two things which happens. There are two things. If the prostate is above and the urethra is like this inferior vesical artery branch which comes as the prostatic pedicle, and the capsular artery which goes by the side. It depends upon the anatomy. Most of the time, the capsular artery is a little ahead of your prostatic pedicle. It doesn't go. You see, the problem comes is when you stretch the prostate on a retraction to see that posterior surface. If you have not dissected it posteriorly very well, what will happen? This capsular artery gets tented into that angle between the prostate and the bladder. So when you make a clip there, the whole pedicle will be lost. Okay. So the best way is do the dissection on the posteriorly itself and reach that area. And then like a Redge sparing, reach that area. So once you do that area, even if you pull, you saw that when I'm pulling the prostate also, only the prostatic pedicle is getting stretched, not that pedicle is getting stretched. So the crucial point here is the posterior dissection. If you have not done the posterior dissection so well, or the large prostate, there was a lot of adhesion. Anteriorly, when you start, you go close, see, you visualize that whenever you are pulling the prostate, this prostatic pedicle and the artery which comes as a capsule landmark artery is getting tented into the prostatovesical junction. And if by clipping it, you may clip it off completely. So this is what is the thing. So that's the reason why people have come retrogradely. They started identify the bare area, go back into the surface of the prostate, come retrogradely and try to save that prostatic artery, the capsular artery, towards the lateral surface. That is a retrograde dissection, which can be possible. I mean, in small prostate, without any inflammation around, it is still possible, very easily possible.
Yeah, thank you, sir. That was really a very excellent video. I think you need to keep on seeing it, and that would give you a more understanding of the anatomy. Sir, Sharma sir, are there any questions? I think
no questions in the
everybody
chat
is
box.
just saying
Yeah,
that it's a fabulous talk. Is
mesmerized.
what.
Sir, your demonstration looked like Virat Kohli hitting Shadab Khan for the 6 in the T20 World Cup. Excellent.
Virat Kohli doesn't make others to do that. I wish I can make others to do what I did. That's only my aim is.
Yeah, definitely. So do you think working on cadavers for the younger generation would help, or it is just because of the view you get in robotic surgery? Because I think less than 10% of our urologists would have access to the robot. As
I understand, but basically
it's not available to all. So for people who are learning and who are doing open prostatectomies, would you say that it is really inferior and we need to do it only robotic to get such finesse in the dissection?
No, I think basically if somebody can take out the bladder, prostate, pelvic structures and start dissecting macro dissection on an anatomy, or probably even with a binocular loop to start with, and then imply that same thing into the robotic picture is going to be good. But how anatomy can be read on a lap or a robotic is entirely different when compared to
entirely different. Entirely different. Yeah.
3D laparoscopy, people are comfortable. 3D laparoscopy instead of those who
No,
can't.
it's not a question. We can visualize everything. We are all trained onto that. We can visualize what it is. But the way we can look at, even laparoscopy can show that. But we need to see, the problem in laparoscopy is getting that there up to that point and trying to get the instruments there is not possible. Whereas in robotic, because of the hinges, it is possible.
True.
Another question from Dr. Abhinav. Can we do similar neurovascular bundle preservation if we cut the bladder neck first and then try to do interfacial dissection while doing prostatic pedicles?
No, I would have shown one more dissection. I didn't want to show that. That's called completely intrafacial. We don't need to cut. We cut the bladder neck. We go between the bladder neck and the prostatic surface and try to retain all the hood. That means the endopelvic fascia, which covers the prostate, along with the puboprostatic ligaments, along with the DVC complex, everything will stay back. That is a complete intrafacial dissection that can be possible. I can show the video, but I didn't want to show that because understanding the anatomy is more important now. That's a different. That's a anterior hood technique wherein we retain all that endopelvic fascial covering on the prostate along with the vasculature, except we go dissect between the vasculature and that into the detusor apron onto the surface of the prostate.
Thank you. Any further questions, ma'am?
So nothing in the chat box as such, I think. So we can maybe request you sometimes later in the year to demonstrate us this dissection within the endopelvic fascia, and it would help us
To have a webcast that probably we have in the second half. we'll write a letter to him.
So definitely,
Yes.
definitely not a problem at all.
Yeah.
Not a problem.
Excellent academic supper for all the viewers.
Any day.
Very
Yeah.
nice.
Thank you.
Thank you, sir. Thank you very much.
Thank you so much, sir.
Thank you, sir. We'll sign up.
We can, yes,
Yes,
sign
sir.
out.
Thank
Thank
you.
you. Sir.
Thank you,
sir.
Arun. Thank you,
Thank you
Sharma.
so much.
Thank you and good night.
Thank
Good
you.
night.
Thank you.